What is going on, wonderful people? Welcome to the Confused Neuron Explainer. Grab your mental markers and maybe a fresh cup of coffee, because today we are breaking down GERD pharmacology whiteboard style. We're going to slice through the confusion of gastroesophageal reflux disease like a sharp knife in warm butter. Medicine honestly makes so much sense once you understand the core mechanics, and today we are going to master this part of the GI tract together. So let's dive right in by asking the most crucial question. Is that fiery burn in your chest just a temporary nuisance from eating way too many spicy tacos? Or is your body's plumbing fundamentally failing? Because think about it, if your internal plumbing fails, your tissues suffer. We have to fix it before irreversible damage occurs. Here's our roadmap for today's explainer. We'll cover the problem itself, our pharmacological arsenal, how these drugs actually work, the side effect catch, strict red flags, and finally, the clinical algorithm. All right, Section 1, the problem. Let's look at the pathophysiology of GERD. What exactly goes wrong in the gastrointestinal tract to give you that horrible heartburn? Well, think of GERD as a faulty roof and acid rain scenario. Your lower esophageal sphincter acts like the roof of your stomach. In GERD, that roof is failing. It's relaxing when it absolutely shouldn't. Meanwhile, inside the stomach, you have increased hydrochloric acid secretion. That's your acid rain. So this acid rain just splashes right up through that faulty roof and literally erodes your esophageal mucosal defenses. It's a dual problem. You've got way too much aggressive acid and an entirely inadequate defensive boundaries. Moving on to Section 2, the arsenal. Let's talk drug classifications. Now that we know the enemy, let's check out the pharmacological arsenal we have to fight back. We essentially have 4 main weapon classes to anchor in your brain right now. First, we have proton pump inhibitors, or PPIs, like omeprazole. Then, H2 blockers, like ranitidine. We also have antacids, like calcium carbonate. And finally, gastrokinetics, like cisaplide. Each of these classes attacks that faulty roof and acid rain problem from a totally different angle. Section 3, how they work. Time for the mechanisms of action. Let's zoom in on the parietal cells of your stomach and see exactly how these drugs wage war. What's really fascinating here is how PPIs actually work. PPIs like omeprazole act as prodrugs. They enter the alkaline duodenum, get absorbed, and travel all the way to the highly acidic parietal cell. Once they're there, they activate and form a stable, irreversible covalent bond to completely shut down the proton pump, the H plus K plus ATPase. It actually takes about 18 hours for the enzyme to be resynthesized. By doing this, PPIs drop acid production by over 90%. It's absolute overkill, but incredibly effective. Meanwhile, H2 blockers take a totally different route. Normally, gastric acid is stimulated by acetylcholine, gastrin, and histamine. While H2 blockers, like famotidine, competitively block histamine from binding to its H2 receptor on that same parietal cell. By doing this, they dial down the acid by about 70%, successfully inhibiting basal, food-stimulated, and even nocturnal acid secretion. So when you compare the two, it perfectly illustrates why PPIs are the undisputed heavyweight champions for severe GERD compared to H2 blockers. PPIs give you that massive, greater than 90% reduction via covalent bonds, making them the absolute preferred drug for severe erosive esophagitis. H2 blockers, on the other hand, give you a solid 70% reduction, which makes them great for milder, maybe just occasional heartburn cases. Let's shift gears for a second. Instead of targeting the acid rain itself, gastrokinetics like cisaplide try to fix the faulty roof. By activating serotonin 5-HT4 receptors, these drugs release acetylcholine in the myenteric interneurons. This induces peristaltic movements, effectively pushing food downwards. And most importantly, it tightens the tone of the lower esophageal sphincter. So it basically fixes the roof and sweeps the floor all at once. Finally, we have our antacids. Now, antacids don't stop the acid pumps at all. They're basically just cool blue weak bases sent in to immediately neutralize that fiery red hydrochloric acid. It's simple chemistry. Acid plus base equals salt plus water. This reaction happens instantly, right in the lumen of the stomach, giving you incredibly rapid relief. Section 4, the catch. Let's dig into side effects and trade-offs. Because remember, as we learn in pharmacology, there are no perfect solutions in life, only trade-offs. Let's look at the dark side of our heavyweight champs. If you leave a patient on PPIs long-term, say greater than a year, you risk seriously crippling their nutrient absorption. Stomach acid is literally required to absorb calcium and vitamin B12. Without it, say goodbye to your bone density. You get a significantly increased risk of hip, wrist, and spine fractures. Plus, altering the stomach's natural pH removes a major defensive barrier to bacteria, which increases the risk of nasty Clostridium difficile colitis and even pneumonia. Now, let's talk about the catch with antacids. It's essentially a tale of two elements. Aluminum hydroxide tends to cause severe constipation. It severely backs you up. Magnesium hydroxide, on the other hand, tends to produce explosive diarrhea. It completely clears you out. And this is exactly why clever pharmacologists combine the two into one formulation. The goal is to cancel out those extreme side effects and just normalize your bowel function.
Now, for a quick rule of thumb, as the medical saying goes, when doctors don't know what to do, they give steroids to you. Oncologists love them, rheumatologists love them. Sure, they might boost antiemetics for a chemotherapy patient, but please don't be the doctor who just throws corticosteroids at absolutely everything. They are completely and utterly useless against GERD.
Section 5. Red flags. We need to cover strict contraindications.
Let's move to the absolute red flags. These are the contraindications that will get you in serious trouble if you ignore them in the clinic. The crucial point here revolved around misoprostol. It's a prostaglandin analog used to protect the stomach, but it is strictly contraindicated in pregnancy because it heavily stimulates uterine contractions. Just never give it to a pregnant patient. Also, beware of cisapride. It activates hERG channels in the heart, which prolongs the QT interval and can trigger torsades de pointes, a potentially fatal ventricular arrhythmia. It is heavily restricted for a very good reason.
Furthermore, beware of the liver and drug interactions. Cimetidine is notorious for inhibiting the CYP450 enzyme system, which basically stops the breakdown of other drugs, leading to dangerous toxic buildups in the blood. And PPIs like omeprazole inhibit CYP2C19. This is actually huge. Clopidogrel is a prodrug blood thinner that specifically needs CYP2C19 to become active. If you give omeprazole alongside it, you block that activation, effectively turning a heart patient into a ticking time bomb. Section 6. The clinic. Let's bring it together with the pharmacotherapeutic algorithm. Let's see how all this knowledge builds into a practical, real-world treatment algorithm for the clinic. Basically, you escalate the pharmacological firepower based on the severity of the symptoms. Step 1. If a patient just has occasional heartburn after a really big meal, start with simple, rapid-acting antacids to neutralize the acid. Step 2. If it's mild to moderate GERD, move up to H2 blockers to cut that acid production by 70%. And step 3, if they have severe, frequent GERD or maybe an NSAID-induced ulcer, you drop the PPI nuke for the worst cases to completely shut down 90% of acid production. And here is a clinical pro tip to separate you from the amateurs. If your patient is on long-term acid suppression therapy, like a daily PPI, their stomach pH is going to be chronically elevated. This seriously impairs the absorption of standard calcium carbonate supplements. So what do? You switch their supplement to calcium citrate. Why? Because calcium citrate absolutely does not need stomach acid to absorb. Boom! That's exactly how you protect their bones while effectively treating their burn. To wrap up this explainer, here are your confused neuron key takeaways. Always remember that GERD is all about fixing the faulty roof and blocking the acid rain. We do this by targeting specific cellular receptors, like the H2 receptor or the proton pump itself, to shut down the acid machinery. But as always, you have to respect the pharmacology. Always anticipate those long-term metabolic trade-offs, like bone fractures and B12 deficiency. I'll leave you with this provocative question to ponder on your own time. With PPIs being so incredibly effective, but carrying severe long-term risks like fractures and C. diff infections when treating a chronic disease like GERD, how do you decide when the cure finally becomes worse than the burn? Thank you so much for joining me today. Keep studying, stay curious, and I'll see you in the next explainer.